Peyronie's disease is one of the most misunderstood conditions in urology, not because it is rare, but because it does not fit into how modern medicine likes to think. And it is deeply connected to identity, sexuality, and self-image. That combination makes it uncomfortable for patients and for doctors. If you have missed part 1, where I explain Peyronie's disease in detail, I will link it at the end. I'm Dr. Stefan Buntrock, one of the most copied urologists on YouTube. Okay, this video will probably not be copied. Peyronie's disease is a major taboo. No creator will touch it because very few men would watch it. But that's not stopping me. Someone has to come up with that kind of information. So what's in the current guidelines? The approach is simple. In the active phase, you treat pain if it exists, manage erectile dysfunction if it appears, and then you wait. You wait until the disease stabilizes. Only after that do you intervene, usually surgically. From a purely evidence-based standpoint, this makes sense. But from a human standpoint, it often fails. Because Peyronies does not feel like a condition you can simply wait out. The penis changes, sometimes slowly, sometimes shockingly fast. Men wake up at night, look down, and realize that something fundamental has shifted. The guidelines leave an open space here, because within the inflammatory phase, guidelines assume that nothing can be done. Sometimes that means 2 years of waiting. So within these 2 years, non-operative things can be tried. And what can I tell you? In some men, these treatments work. The angle can be reverted, but not routinely. This applies to a small subset of patients. However, the message here is conservative treatment isn't useless per se, and it only works if the hard lumps in the penile shaft are invisible upon ultrasound. Invisible means there is no calcium deposited inside them. In medical terms, we speak of calcifications here. In my experience, they are resistant to any treatment. It's a different situation in non-calcified plaques. They may respond to multimodal treatment. These therapies target disease progression, erectile pain, penile length, erectile dysfunction, and curvature. Curvature is the hardest of them all. Now, here's where things start to become complicated. Peyronie's disease has no lobby. We don't know exactly how many men really are affected. Many are too ashamed to show up at any doctor's office. But probably it's up to 1 in 10 men. We're talking about a disease that's as frequent as diabetes. For diabetes, we have disease management programs. For Peyronies, we don't. Taboos don't have a lobby. This is why treatments often are not guideline-based. If I was to name the single most important component of any conservative treatment, I would pick traction. Especially when we talk angulation and penile length, success becomes very unlikely without some form of traction. There are special devices designed for just that. Because of laws and regulations for medical professionals in my country, I must not tell you any name or recommended device. Vacuum pumps can likewise be used for traction, but frankly, I think they have a major drawback. Traction probably is only effective if done for a sufficient amount of time. Vacuum pumps can only be used for 20 minutes at a time. That may not be enough. In addition, heavy or prolonged use can lead to venous congestion and bluish discoloration. If you suffer from Peyronie's disease, it is mandatory that you talk to a professional about it. A video can't replace that and isn't medical advice either. But it can be a start into this complicated topic. Peyronie's disease needs more public attention. Early interventions can help to prevent the disease from showing its ugliest face. You want to know what that is? Then watch part 1 of this mini-series. I'm Dr. Stefan Buntrock, always copied, never matched.